Welcome to this session of Bridging the Gap between Nordics, Bulgaria, and the SEE countries, and seen in the light of Movement Health 2030. So Movement Health 2030 is an idea on bridging between countries, in countries and between countries on several levels to improve health. One of the basic message we have is that 80% of health challenges are very similar around the world, which is why we should begin to work much more together. But it's also a way of trying to work more or less in the same way in several countries. We are active in 29 countries now, and the Nordics and Bulgaria are also part of that. So how can we push together forward? And one thing is to push policy changes. So in Europe, we are of course connected via different networks, EU and others. But it's also on how we can scale ideas from each other and help bridge. So one of the things that we have, of course, had on the agenda with the Nordics and Baltics and Bulgaria is, can we get some of the knowledge into Bulgaria to work, but are there also things that we can begin to work with in Bulgaria, which also would help both the Nordics and other areas, both in Europe and in the world. So, and it's also an approach where we have half of the focus on the long-term policy shift of really getting to a more sustainable and equitable health system, but also to work with pilots, practical pilots, to solve issues today. And it's also pushed forward because we can see that there is not really economic sustainability in the system as we see them today. That is one side. And the other side is that we have really a hard time in the way we are thinking health to really implement new technology, new concepts, and also use of data in it. So a part of it is also really to think health as the most important societal pillar, and also see health as an investment and not as a cost. So with these words, I will give the floor to Nard Schreurs, who's the director of the EHIN conference in Norway, but of course he's Dutch. He is, I think we can call him Norwegian anyway. But Nard, would you please take the floor?
Yeah, thank you. Yeah, thank you. I see now I can also share the presentation. I tried it. Hello, everybody. My name is Nard. I tried to. I'm not sure if you can share the PDF I had yesterday.
Yes, I will.
Because
Okay.
it seems like my system is a little bit.
Yeah, Gergana will share.
Yes. Well, anyway, there it is. So, European Way for Health, Bridging the Gaps. Next slide. If you can get that. There's at least activity. Great. Okay. I will tell you shortly a little bit about EHIN, about Norway, about the future of health, what is digital transformation, and how we can look at a new model and build Europe as an alternative for the existing models. And as I only have 7 minutes, I will just dive quickly into it. Next slide, please. EHIN is standing for eHealth in Norway. I'm leading this. This is a conference, a meeting place. We have had like up to 1,700 people in Norway and from the Nordics. We really try to connect different players from the industry and from the public sector, as well as politicians. The woman in red is our new health minister in Norway. We have a conference once a year, but we're also extending to a year-round platform with webinars, podcasts, and we're now launching a health data day in different ways. So we are in Norway doing what we might look if we can do it in a more international way. Next slide. As Bogi said, I was born and raised in the Netherlands, but I moved for almost 30 years ago to Norway. It's a long country along the coast. It's only 5.5 million people. It's not a member of the European Union, but it's very connected to the European Union and the rest of Europe. We live with 4 health regions and a lot of municipalities who all have to work with healthcare. And we see that the industry is moving from oil to healthcare. Healthcare has been very hard to get investments because the oil and gas industry in Norway was very strong. We see that that is changing now because of the climate crisis, and there is a lot of new innovation in Norway, which is also connecting to universities and other research institutions, which is connecting to the municipalities and the health regions and the hospitals, things over there. And we see that there's a new need to work on a more public-private way together. Norway has a fully public paid healthcare system. There are so small niches which are private. So it's an interesting way to see how we can work together with the industry and this public healthcare system. Next, please. So the whole world, as Bogi said, has the same challenges. One of the biggest challenges is the changing demography. We're always talking about the silver tsunami and see it as a negative thing. I think it's pretty good that we are getting older, but it also means that we have more chronic diseases. We see that cancer is getting a chronic disease because we are so fortunate to be able to help people with it, but it means that the burden on the traditional healthcare system is getting bigger and bigger. We do have not enough people, we do have not enough money, but we do have data, and this is the interesting thing we can start to look at more. Next slide, please. So there is a transformation, and it's been starting for some decades ago, and it will continue some decades ahead. But we are in a kind of gearing up situation where we see that the speed of the transformation is really is speeding up, and it's from there it's very interesting to start to discuss in a broader way where are we, what is the traditional way of doing healthcare. And where are we going? How is this going to look in a totally digitalized world? And where are we now? How are we getting from where we have been to where we are going to be? And how are we working with our ethical thoughts and a lot of other things? So there's a lot of thing about what is healthcare data. Healthcare data is traditionally something that doctors and nurses make around us when we get ill. But in the future, and already now, we'll see that healthcare data is just scaling up in every direction. It could be genomics, it could be Internet of Things, it could be Internet of everything. It's getting very personalized, and the idea is how can we work in the transformation, adding all those data into a trustworthy system, so we can use them for a greater good. Next slide, please. And when we were working on the Nordic Health 2030 process, which Bogi was leading and which is the base of the movement 2030, we found out that we have to go to a much more preventive system. We are looking to an existing system which is very much healthcare, sick care, but we have to go to healthcare and make us not getting sick. And we need to use data as a part of that. Next slide. And in that, we see that we try to make a Nordic model, which could be an alternatively, if I put it some bluntly, in 2 axes. We have the American US model, which is very based on commercial ideas. It's very individual based, and it's using data and money in a very individual way. And then if you look to the China model, which is very much based on society for the greater good for everybody, but the individual has no rights into that. And we're looking for how can we build a Nordic model where equality and humanistic values are in the center of this digital system, and which can provide healthcare in the same way for every person in society. Yeah. Next slide. Okay, well, that was the end, and the idea is then that this Nordic model can go into a more European atmosphere where we can see how can we, as Europe, build our own alternative model, which is not depending on the American commercial way of thinking. And that means that we have to start sharing and try to build meeting places and different ways of sharing our thoughts. Yes, that was very shortly the 7 minutes I got from you, Bogi.
Thank you. Thank you. I hope I can be more generous with time at some point. And thank you so much. And what we will also take it into discussion on how we leverage these kinds of ideas across from the Nordics to Bulgaria. And I can see that Lars Münter is on now. So if you're ready to just take the floor with your 7 minutes, that will be good. Welcome, Lars. Oh, you can just put a line on where you're from.
I
cannot hear you. I now can hear you. Yes.
Yeah, good. Actually, I can't unmute myself. So, but anyway, but thank you very much for allowing me to also be here. My name is Lars Münter, and in my day job, I'm part of the Danish Committee for Health Education, and then as thus working quite a lot on various topics that are revolving around empowerment, self-care, providing different opportunities both for the citizens and for the system per se to allow people to focus on their general health and well-being. Our organization do not work per se in the clinical area, but realize that most of people's lives are actually lived outside of hospitals. So in that, reflecting that, we also need to see as a society or as a system how we can support people's lives when we're talking about health. Well, not in the clinical system. Obviously, we want the best care for them while they're there, but there's an awful lot of life to be lived outside of the hospital system. So that means, of course, looking at how, for instance, we prevent stuff from happening, how we promote health, how we rehabilitate, and so on. And this can be done, of course, in various ways where we sort of provide services to someone, but it's very much in line with the overall Nordic Health 2030 movement idea that it can also be done by recognizing that the citizens themselves are actually very powerful agents or potentially very powerful agents for their own health or for community health, meaning that of course they have the resources to either build communities, they have the resources to build various initiatives of some kind that would allow them to be more active, to be socially. Actually, one of the initiatives that we in the DCHE specifically have used in energy on the last couple of months is to transform a case from the UK in Frome, where they in Frome have targeted loneliness specifically, especially because the issue of loneliness has a lot of other traditional health impacts. People that are lonely tend to drink more, smoke more, exercise less. And if we as a health organization would focus only on getting people to not smoke, not drink, exercise more, we would fail to see the bigger picture of that element of the loneliness. So we try to focus on that, and then also realized that the people that are lonely are only a symptom of a sort of a deficiency or maybe of a lack of social cohesion in a community. The people that are lonely are, of course, the ones that have often a deteriorating health. The people in a community that are not experiencing loneliness, they are also a less social cohesive per se than they could have been. So when we try in our new project in Denmark, we focus not on loneliness, we focus on togetherness. We want the people that are lonely to, of course, to be not lonely, but we also want the people currently not lonely to experience more social cohesion. What we know is that this will boost their social interaction. This will boost their mental health. This will boost their physical health. They will tend to exercise more. They will tend to drink less. They will tend to smoke less. And then we will actually solve a lot of different issues. But the solution here lies in supporting a social cohesion in the community. It doesn't lie with building another hospital or building another health clinic. It lies completely elsewhere. And we as a health organization have to figure out a better way of doing that in collaboration with the local housing societies, with the local football clubs or other kinds of sports initiatives and so on. That is our job to, in many ways, coach, nudge, support a local community interaction. That is just, this is meant as a case, though, in this relation. But we as a health actors could have chosen a more traditional approach, and I'm smiling here, of thinking we need more nurses, we need more doctors. We have to fix those smokers, we have to fix those. But we're trying to go a little bit upstream and try to look at it differently. And I would urge, when we look at different types of solutions going forward, we think of our communities, of our people as resourceful, as perhaps not as health literate as we would like them to be, but thinking of this case originally and ask the question to ourselves, were we as health literate in our organization as we should have been when we formally focused on the lonely, on the smokers, on the drinkers? We should have thought differently if we were really health literate.
Thanks, Lars. I think really important, and also that you have a good institution to take a different approach to things. And I think the bridge here with what we want to do, Nordics and Bulgaria, is that in Bulgaria building a system of the future, it's possibly a bigger room to get these kinds of ideas in from the beginning. So I think that's a very good point to dig in here. So Lars, the other Lars Lindskold, would you take the floor, please?
Thank you very much. And thank you, Nard, and my fellow named Lars, for your presentations. They were valuable to listen to. I like the idea of a Nordic model, but I think we need to talk about the European Union model or Europe model and so on. I like your discussion, Lars, about the prevention. I think the only way to be healthy is to continue not to be sick. And that is what prevention is about. I had made some slides, if you can bring them up perhaps. Or I might share them myself. I'll see if I can do that.
Okay, would you like you to share them or?
It doesn't matter. You can share them.
Okay, they're coming.
And thank you for the invitation, Bogi, to participate in this panel. A first reflection is that we are a lot of old men in this panel, and I say no more about that. But I like the idea of bridging gaps. I think one of the things I see more and more is that bridging the gap is actually making sense for the societies. And they see more and more that you can't be alone anymore. You need to cooperate with others. And that's thanks, I guess, to the digitalization that we have seen. I like your approach on this panel, how to work with the South and Eastern countries in the frame of Movement Health 2030 to improve it. Next slide, please. As you can see on the previous image, I'm actually into diagnostics. I'm like radiology. I used to see through things, to try to find what I can see that nobody else sees. And when I thought about your frame of this with the equality and access, the preventive care, data and digital infrastructure, and actually the last sentence there, moving from strategy to implementation. Because in somehow I feel more and more that the important thing for us now is to do the implementation. And the interesting thing when you do digital implementation is that it's not so costly to fail. And it's quicker to back if it fails, and you can try another way. And when you look at the map here, you see we are up in the blue. We think we are the best in the Nordic part of the world. But you also see that we are a lot of cultures. So that's an interesting thing also with the culture and the different languages we have here, if we compare to China and if we compare to the US. So in a way, we don't have the huge market, but we still have a lot of people. Next slide. So one of the things I'm really interested in to be a part of and support and discuss is the semantic interoperability. I have talked with my students, I used to say the machine readable is the future of Esperanto. And then they look at me and say, what's this Esperanto? But you know that Esperanto was a philosophic thinking of bringing the word together, to have the same language, to understand each other better. And for me, the machine readable here, with the use of data and the digitalization and the flavor with artificial intelligence, could make that word happen. That we have a common language that we can communicate with. I think if you hit next. And I've been researching a lot in interoperability. And the first thing is that it's a very difficult word to pronounce. And it's an even harder word to understand. But I used to say the simplest way to understand interoperability is that it's the thing between. And it's the thing between nobody would like to take care of. So that's why we are building these platforms or big systems in healthcare and so on, because we don't like interaction. We like integrations. And it works sometimes, but it also slows down. So we need to work on the interoperability issues for the future. Next slide. So I think one of my learning lessons during my life is to work with prepare to share. To understand how we as organizations need to prepare ourselves of actually starting to share. And we have seen now I would like to say the paradigm shift that we see in the whole world of more open source, more fair principles and so on. So we are starting to prepare to share. The things that happens after you have prepared for that is when you start to sharing, nobody cares. So that's also a difficult thing of understanding that it takes some time to have others to be involved with you and work with you. I think Lars addressed it very fine with the understanding on how in the hell are we going to help people to keep their health. It's really nothing we are used to do. It has been a personal responsibility before and so on. But I'm sharing, who cares? And the latest thing is sharing is caring. And you see the heart on that image there. Sometimes when I talk with people from healthcare, I used to say, you all know that digit means 1 or 0. Digitus is the name of the finger, and digitalis is the pharmacy we use for heart problems. So in a way, digitalization means something that we care and love about. So if we hit next. So when I thought about I see that prepare to share is about equality and access. And hit next. I'm sharing, who cares, is for me a discussion of preventive care, what we can learn from each other, as you started to talk about, Bogi. And last, sharing is caring, the strategy to implementation. And that's one of the things I also learned a lot when it comes to data. If you find a method, you can actually implement it in so many domains. That's very interesting. And if you hit next again, you see that for me, the most important thing to bridging the gap is to have a digital infrastructure that can be shared and work together with, and where the data can be the energy on that infrastructure. Because data is a fascinating thing because it will never disappear. You can't take it as you do with something else and keep it and nobody have access to it. It can just be in so many shapes all the time. Next. So with that, I'm in the mood to move together against 2030. Thank you, Lars.
Thank you so much, and we will take that also into bridging. And this was the European approach, so that's very good on bridging with Bulgaria between the Nordics. Thank you. And Pekka, you are our technology officer at the Helsinki University Hospital, and I have also worked with some really exciting ideas on how to get things realized in different ways. So please take the floor.
Thank you, Bogi, and thank you for the invitation to join this session. It's really great pleasure to be in this panel. I'm sharing some experience that we've had at Helsinki University Hospital about doing the digital transformation. It's maybe more focusing on our learnings and our path, but maybe some of the key principles are very valid to this discussion in bridging the gap between the Southern East European countries and the Nordics. Our working name for this particular project has been Digital Health Village. Can you see my share now? Good. So the idea being that we have a transformation challenge in hospitals. So for all the reasons that everybody knows, there's a big sort of pressure for hospitals to transform the way of working from the old-fashioned type of waiting for patients to be referred to a hospital and then
Pekka, I think we're seeing your screen and not your window, so we can see.
Okay.
Yeah. So we see your presentation twice.
Okay. I can share. Okay.
Okay, please. Yeah.
Yeah.
The common problem with too many monitors.
Yeah, it's so practical otherwise, but this is yeah. Thanks. So if you take the next slide, so the challenge with hospitals in doing the digital transformation is that the promise is there that this will sort of change everything, but the practice is that when you start the work, it tends to increase costs in the beginning because you're doing a lot of investment in the infrastructure, in training, in taking the new technologies into use. But unless you are able to transform the sort of traditional processes aligned with the digital world, it will never get the value out of it that is the common goal. Then there is the other problem is that there are lots of small proof of concept studies or pilots that are really nice to show that these things work, but how do you move from those into a large scale application? It's really a really difficult problem, and the larger the hospital, the bigger this problem is. Helsinki University Hospital is one of the largest healthcare providers in Europe, so we have 27,000 people working for us. So you can imagine that if we do a small pilot on one clinical specialty, it's by no means any guarantee that this will have any impact unless it's somehow from the beginning thinking about the scaling. And then it's the question of disciplines. So as you know, specialized care is a field of very high valued clinical disciplines. And all these disciplines are facing a supply of digital solutions that are best of breed. So companies best in the world, they develop them and then they market them forward and say that this is the best cancer application, this is the best cardiovascular thing, this is the best diabetic management thing. But clearly, from a hospital's perspective, you can't get the best of breed individually for all clinical domains because it just becomes too expensive, too complicated to manage. So how to tackle this challenge? And our approach, if you put the next slide, please, is to work with this type of concept that which we call the health village, which is partially it's IT. It's partially it's IT. It's providing a platform for digital services, but then it is also about content. It's about generating content that can help in transforming the traditional service delivery into a digital or a combination of digital and traditional service delivery. And then it is about a transformation process. So how to do this in practice. And the key thing is there that nobody from the outside can do it. It has to be given to the clinicians, to their hands, and to have such tools at their disposals that allow them to maximally do the transformation by themselves and not make the IT people or the IT vendors a bottleneck for that. So it means a lot of sort of modular, standardized technical tools that can be then used and designed to a large extent by the clinical teams themselves, because then it sticks. It will not stick if it's a project brought from an innovation department or something like that. And this is a great learning that we've had, and it's quite successful. And now providing this experience as a seed for discussion in this context is our contribution. I have a few more slides which are available for the audience, but I would not be using more than my 7 minutes. Maybe taking the next slide very briefly. So it just shows that we have sort of a technical platform which is a modular cloud-based thing, and then there are disease or patient group specific implementations of this with content and with modules that are being used. And these are all available for learnings, and it proves to be fairly scalable. So we have been able to create these patient-specific digital care pathways, more than 100 in a few years. Of course, the practical transformation in the clinic, how do you redesign the process when patients still need sometimes come to the clinic? How do you redesign that? It's still in progress, but it proves to be somewhat scalable and applicable over different clinical specialties and in different types of treatments, from operative into chronic care, into training and long-term conditions as well. So if you take 2 slides forward, so I would just conclude with our idea that the key here is to prevent hospitals becoming inflated. So with all the possibilities of modern technologies and treatments, there is a clear risk adding digitalization on that. The hospitals will become inflated. They will just suck all the resources from the healthcare system, and it will never be enough. So our idea that with this sort of transformation, the hospitals could be kept, at reasonable size, even de-sized in some points, because some of the care could be transferred to home or to primary care. And then this enables data-driven services. And our vision is that it's something that we've been doing in Helsinki University Hospital, somewhat in the public healthcare in Finland with other public providers. But this could be a start of an ecosystem where different players around the globe, if needed, could work on this same concept, and the software modules and the contents are available for further use. So I will conclude here. Thanks a lot.
Thank you so much, Pekka. Very interesting and very concrete, and maybe also one of the things where we concretely can begin to think how can this also work across to Bulgaria and southern Eastern Europe. So Stanimir, I can't see you. Are you here?
Yes, I'm here.
Okay, good. So I mean, you have been long term the leading figure in the Bulgarian patient organization. You have worked very much on the European level on the patient question, and you are also leading the personalized medicine coalition, or you're chairing that one in Bulgaria. And so what are your thoughts on this? How we leverage on the collaboration in between the North and Bulgarian and Southern Eastern Europe, and maybe also where should we start?
Thanks a lot, Bogi, for the invitation, and it's really a great responsibility to represent the entire country and the region in this very important conversation. Maybe next time it will be much better if we have some more representatives of the region to hear different opinions, etc. But I'll try somehow to express what's the situation from our point of view. Of course, the change is needed, and I don't think there's anyone in our countries who doesn't want a change towards a better system. There's nobody who doesn't want to close the gap between East, West, North, and South. But the problem is, what is really the gap? And then once we know what's the gap, what are the potential bridges that we can use to close this gap? And besides what's obvious on the surface, the huge differences that we have among our systems, I think there are some deeper problems that are in the basis of these differences. Of course, here we can mention the cultural difference, the historical ones, and whatever we can think of. But I think that one of the biggest challenges is, and most likely it will continue to be in the future, the economic differences between the countries. And having this economic gap, which is a starting point of any healthcare system, so it's really the resources available in a country to transform, might compromise any good idea or cooperation or transfer of good model. I'll try to be very concrete why I think this is really important and should be acknowledged and bridged in the future. Not that money should flow to countries like Bulgaria and Central Eastern European countries, but we have to acknowledge this huge difference and to see how we close these bridges, what kind of bridges we use to tackle the situation. For example, regardless what we do in our system and transforming it and shifting healthcare from hospitals, which is extremely expensive, and Bulgaria has huge number of hospitals. This is clear. I think it's one of the biggest in Europe and in the world per capita. But even if we do that, still Bulgaria needs to pay medicines at an European price. Regardless what budgets we will put here, the Bulgarians and many other countries around us are 10 times difference in the GDP compared to our to the countries that you represent. And in this huge gap, regardless of the willingness of the government or the knowledge that you have in the country and the expertise there, it at the end comes it is a matter of money, and somebody has to find this money. Unless when we talk about fairness and about solidarity in Europe and about nobody left behind, we find a way that we have more fair distribution between the costs. Now, for the costs of the healthcare systems, because at the end, as we saw with the COVID, the healthcare systems are not isolated in the countries alone, but somehow they are already interacting between each other. And if we don't find a way for the weakest systems to become stronger in the future, including economically, then we will compromise anything that we do, regardless how good is the practice that we want to transfer anywhere. So this was just a small example of the pricing of medicines. There are many factors, you know it probably better than me, but the prices in Europe are European prices. That's it. We have a list price, and regardless how poor or rich is the country, this is the starting point of negotiation. And having in mind the size of the country, comparing to Norway, we are maybe double, but compared to the economic power of Norway, we are far behind. So at the end, some countries might achieve quite better prices, being wealthier countries. So this is a key issue for us, but of course there's lots to be learned and lots to be done in those countries. I heard from the previous speakers very nice ideas about the infrastructure, for example, which is good to say, nice to have, but I can give you also examples here. In Bulgaria, we have recently launched the so-called supercomputer. I think we even have a second one right now in the country. Don't have really details on how the money got in the country, but as far as I know how it's happening, there are some money that are not used from European funds or other available money, and sooner or later somebody is pressing a politician here to take the right decision. So now we have a supercomputer. We have a second one in a way, or maybe even a fact already, and both are not used properly, but not used enough, I must say, not from the Bulgarian scientific society, not from other countries. So is the infrastructure the answer alone or in a silo? So to any of the other arguments, I might put such arguments not against them, but something to be considered. And if we don't replace these gaps, we cannot really move forward, and we will continue to be in a situation where small pilots are done here and there and not implemented afterwards. And we will continue to talk about how important is the region to develop further. But if we don't find the solution for these essentials, then it's really a challenge and a problem. Last sentence, if you allow me, Bogi. Just an example, because I like to bring the region through examples rather than talking much about theories. Do you know that until recently I had to lie Amazon that I live somewhere in the center of Berlin or United States or whatever, so I can order just a small speaker for 15 euros to have access to a voice assistant, which is a technology that is widely used currently, or in the future will be widely used, the voice technologies in healthcare. And Amazon just launched a brand new program for the next 3 years to develop the healthcare voice technologies in the hospitals and everywhere. So I personally have to lie Amazon that I live there, so they can send me this speaker somewhere in Berlin to a fake address, and from there I have to organize the transport to Bulgaria. If we don't have equal start for those countries, if we don't have equal opportunities, we cannot expect equal chances to develop further. Thank you.
Thanks, Stanimir. And this is also a very good example on that. This is not just about the responsibility from the public sector. It's definitely also responsibility from the commercial sector in order to push forward. And thank you, Stanimir. I think I will take this question on the bridges and going beyond small pilots. So if I could ask you other panelists to very shortly in about a minute or not more than 1.5 minutes to come with some concrete examples which we could try to see if those are the bridges. Is there one who wants to start? Maybe Pekka, you can start, because your arsenal from the digital village is so big. So if you can take maybe one example from there.
I think that the bridges nowadays building virtually are, you know, offering great opportunities, because the first initial step to get people, you know, connected is so like business as usual. So I think that that at the same time as there are these big fundamental undertows that changing them will need much more effort on the policy and other political levels, there is still like a very low threshold, lower than before, to get people, you know, engaged with each other, and also sharing and maybe even running these technological pilots, which are not requiring a huge infrastructure to begin with, but could be started with a fairly low level. And the idea, what we've been sort of bringing forward is that because it's a solution adopted by a public hospital, it means that it is probably a bit less biased into certain commercial sort of endeavors, but it's really aiming at transforming the healthcare system. So I think building, you know, virtual bridges is a good start, because nowadays it's so business as usual.
Very good. And yeah, Lars Lindskold.
It was actually building a bridge when it came to cancer. We had this beating cancer project that was with a pharmacy company. But I think the most important thing, like Pekka said, is to bring people together. So I will make sure that we send out some more invitations about the Sitra network from Finland that is running very good. And there is international one, and I know the most you are onto that also. I think that it's so complicated when we try to have countries to work together, because then it starts to complicate. So I think more and more people are the thing to work together. And the last thing I would like to support is obviously supporting the semantic interoperability, sharing the methods of using SNOMED, OpenEHR, HL7 Fire, and so on. Those things are quite easily shared. Thank you.
Thank you. And yeah, Lars, the other Lars.
We've got an ample supply of Larses in the north. But I would suggest something that's in a way is fairly low tech, of course, building on my example before. The case that I told you all about was us using a case from the UK and transfer it into Denmark. We know of a similar case happening in Utrecht in the Netherlands, meaning that you have various places, communities, cities, in the sort of the same way that you see the C40 cities working with climate change and energy efficiency and so on. You can do the same, building bridges across communities and cities that are working to this. We've looked at the concept, not necessarily the same as the healthy cities, but looking at sort of connecting the social connectors in these cities. There's a lot of different things about how you actually engage communities and housing opportunities, how you actually build bridges in the community among from various sectors to do this. And this is something where the bridges among, well, Lars's example before, to get the people together is really, really helpful.
Thank you. And Nard, if I'm not totally mistaken, you're from Utrecht, right?
I am from Utrecht. It's the center of the world, you know. Great city. So there's a lot to say about this, and I totally agree with you, Stanimir, that it's about that there's a lot about difference in possibility in your economics. On the other hand, I see that digital solutions are very scalable. It's the scale which makes them strong. And I think one of the things, and now I think a little bit from the vendor side, those who are developing the solutions, they need a bigger scale for bringing their solution really in a bigger test bed, because Norway is only 5 million people. So I think to work more Nordic and have other parts of Europe connected to it, it will also create a value for those startups, for those companies who are working with their solutions, because they need a bigger scale to take the next step outside of Europe and go to the United States or whatever. So I think the opportunity to have a country which is willing to be a part of developing solutions could be one of the many ways to go ahead. So I think there are possibilities there.
Thank you, Nard. Yes, Lars, go ahead.
Comment when I thought about it. In Pekka's hospital, the University Hospital of Helsinki, we are running a program together with Sahlgrenska University Hospital and Landsspitalen in Iceland to see if we can use the sepsis algorithm for small children from Helsinki University Hospital, how much it would take us to bring it into Sahlgrenska and into Landsspitalen. And those new approaches of sharing is quite interesting if we can start to have companies that help us with the other parts, and not as they do today, they build a whole system for us to use and so on. So that's something that hit me now, that sharing algorithms in the future might just be a very good way to quickly came up to some more people. Thank you.
Good, thanks. So if I can push another for the last 5 minutes. So what we really want to get forward with the movement health approach is the scaling that you were talking about, Lars. Of course, it needs to be adapted to. And if we now use the wording of Stanimir on identifying which bridges, because I mean, I think that's also where we see a lot of failures. We might have the scaling potential, but we just take the first bridge. We don't really think about which bridge in it. So maybe this group that is here is willing to take and can be an asynchronous online brainstorm, but really trying to think about what can we do, and with the help from Stanimir and some more of his network in Bulgaria or in Eastern Europe, he's also assembling quite an important high-level expert network in Eastern Europe. So we can think together. I mean, what makes sense? What is it? Because it has to make value. I don't know if that's an idea you would buy into, that we could try to push without complicating things. And of course, it needs to be in the areas that you're already working, or else it's hard to get time on it. Yeah, Lars.
Again, I'm a big fan of cascading models, things that can evolve by themselves. We've used a model that we've worked with in various countries that we used to for a long time ourselves, but we also implemented it in Moldova, meaning this is something that you don't necessarily need to be I'm not pointing any fingers, but you don't have to be a rich Nordic country to do this. This can happen in most settings. The cascading model here is about actually setting up a peer-to-peer support group that over time can actually lead people to better manage their chronic diseases or life crisis and so on. And it can be done in Moldova, and you can then mirror that in various communities and so on. It's a sort of a slow-moving process, but it's a cascading model. So once you get the snowball rolling, yes, you're actually on the fast track to real change.
Okay, and now I'm just gonna be a little bit pushy because we also need to wrap up. But in here we have Stanimir and of course Lars, which has the, what can I say, outside of hospital really approach with some and an institution which has a half a century of experience in that part. Pekka, who with the Digital Village is sitting on maybe one of the most interesting innovation engines in Europe. Nard, which is sitting with one of the most important digital health conferences in Northern Europe, that could also be a gateway to it, and Lars Lindskold, of course, who sees through everybody and would know where the bridge ends, but is also very deeply into what he also mentioned with the CITRA and the different European networks as well. So if we combine a bit of this and think, I mean, are there some steps we could do together? And of course, as Stanimir said, we need to have the intelligence on what really is needed and how to start. Is that something that we could agree on? We would want to make a next step on?
Yes, sounds good. I mean, starting to bring people together and sharing ideas is a very good start, but you have to make the next step and make them concrete, because ideas don't
Yes.
sell and you can't eat them.
No. So I think what I'm envisaging is that we throw out some concrete challenges that we need to be solved, and then we can begin to work with that. And if it's not ourselves, then we would know who in our network could step in.
I'm a big fan of intelligence.
Very good. I would like to
But
thank
Bogi,
you.
just a
Yeah.
remark. I mean, I just love the book that you stand behind, the Nordic Model 2030. Shouldn't it be a challenge to create the European Model 2030? That we
Yes.
so then we could find some financing and all these things also, and have these think tanks and share them and eat in, and I mean the Vitalis in Sweden and so on, so we get the word around, so to speak.
Yes. No, I think that could also be a very good idea. So, and this is also what we want with the movement health, is that we have the aspiration, so we know where we want to go, but also the practical things. Where do we start? What do we do tomorrow? And I think that in the room here we have the competences to take that. So thank you so much for spending time with us, the audience, and for you, the panelists, so much for your inputs. This was really good, and only the beginning. It's not even the end of the beginning, as a famous man said. It's only the beginning of the beginning. So thank you so much, and enjoy the rest of the day.
Thank you. An applause to Gianna that made it happen also.
Yeah.
Thank you. Thank you.
Thank you, gentlemen. It was a great discussion.